Good afternoon. My name is Omar Latouf. I am professor of cardiovascular surgery at Mount Sinai School of Medicine. It's my privilege and honor to be with you today and to introduce to you two of my distinguished colleagues and a third one whom we hope will join shortly and discuss an important topic of cardiovascular disease and how one could reduce those risks and how to prevent a sudden cardiac death. Allow me to introduce my colleague and friend, Dr. Osama Samuel, Associate Professor of Medicine and Cardiology at the Mount Sinai School of Medicine and Clinical Director at Mount Sinai Union Square Heart Center and Associate Director of the Cardiology Education Program at Mount Sinai, Beth Israel. Dr. Samuel, welcome to our program.
Thank you, Dr. Latouf. It's a privilege.
Thank you. And allow me to introduce my friend and colleague, Professor John Puskas, Chairman of the Department of Cardiovascular Surgery at Mount Sinai Morningside, Mount Sinai Beth Israel, and Mount Sinai West Hospitals. The three of us will have an opportunity to have conversation with you today on how to best protect your heart from events, particularly during this prolonged COVID problem that we have encountered. And in that process, I'm going to ask my colleagues to share some thoughts, to start by sharing some thoughts, some stories, and tell us the fruits of their experiences. Let me start with Dr. Samuel. Dr. Samuel, please give us a few minutes of your thoughts on cardiovascular health, and particularly under these difficult times.
Obviously, we are going through a period of significant stress, physically and mentally, for half of the world, if not all of it now. And during this kind of stress, there is increased inflammation, increased blood pressure, increased heart rate, and we see a lot of patients get cardiovascular events during stress. Another component is the concern of making it to a hospital. There is significant reduction in the number of acute presentations with heart disease that we are accustomed to seeing during the epidemic. So we had a paper at Sinai that the number of aortic dissection, a condition that we kind of know the average number of cases every month for the last couple of decades, and it's usually very stable. And we had a significant reduction in the number of acute dissection presenting between March and July. And the fear is that they didn't really decrease in numbers, they just was afraid to come to the hospital, and many of them unfortunately may not have been diagnosed or treated, and this is usually a very fatal condition if it's not treated acutely. So there's a lot of concern about patients coming into the hospital if they have any cardiac symptoms, and there is increase in the risk of cardiac symptoms, and of course COVID itself have a lot of cardiovascular effects and sequelae. We have in Mount Sinai Union Square post-COVID care for patients with cardiac symptoms after recovering from COVID, and we're seeing a lot of patients with this. So I would just recommend that people try to de-stress, do healthy approach to this kind of crisis, continue to eat well and exercise. There is something with staying home and staying close to a fridge that encourage you to do some bad stuff. So please behave and try to keep your mindset, and then also seek help if there is any acute symptoms that you cannot understand, because we do not want to delay care or not provide care that's necessary.
Dr. Samuel, this is a fantastic prelude that you have shared with us. I'm going to turn over to Professor Puskas, who ends up receiving those patients, and many of them at a delayed time. And I would like to ask Professor Puskas to share with us his experiences during this period and his recommendation for our families and friends of what they should do and how best they can take the advice that Dr. Samuel have shared with us. Professor Puskas.
Thank you, Dr. Lattouf. And again, it's a pleasure to listen to Dr. Samuel. I always learn something from Osama. We have had an extraordinary year, to say the very least. And when I say we, I mean we human beings, not just we healthcare providers. The whole globe has been affected. You can see from my backdrop, I'm not presently in New York, but I was in New York for the entire pandemic peak from March through to June. And it was a remarkable thing. One of the things that it spawned was an immense amount of fear. And while we suffered numerous deaths in New York City directly related to COVID, I think that when the counting is done, it will be found that we lost about as many people from fear of COVID as from COVID itself. By which I mean that patients who ignored or avoided their healthcare providers because of fear of contracting coronavirus actually died as a result of absent healthcare or missed healthcare, especially for lethal conditions such as aortic dissection that Osama mentioned, but just good old-fashioned myocardial infarction or heart failure. And when I say that, we used to have a cadre of patients that were admitted relatively repeatedly with heart failure. It's one of the great challenges of modern medicine is managing the patient with significant heart failure. These patients are often admitted, treated, managed, made better, and then go home, and they may come back and be readmitted 2 months or 6 months or 8 months later. And so we had this group of patients that used to occupy a certain number of the beds in our ICU on a regular basis, even to the point where the nurses knew the patients by first name and vice versa. Well, those patients are gone. The whole group seems to be absent. And my fear is that they've passed, that they've expired at home because of fear of coming to the hospital. A particular patient that sticks in my mind was a healthy gentleman in his late 60s who suffered a myocardial infarction and had classic chest pain symptoms, really very easy to diagnose, even for an ordinary layperson. This wasn't a difficult or tricky presentation of massive myocardial infarction, but the patient was terrified to come to a hospital. He actually lived in New Jersey, and the area where he was in the middle of the worst part of the pandemic, and he toughed it out. And when he could no longer stay at home because of severe shortness of breath, he presented to an emergency room in New Jersey and was subsequently transferred to us. But by the time he was transferred to us, he had developed a very severe complication of his heart attack, which was a ventricular septal defect, a portion of the muscular wall that separates the right and left pumping chambers of the heart had been destroyed by the heart attack, and that had ruptured, and now the patient was in profound heart failure. And to make a long story short, he was in such terrible shape with multiple other organ systems failing, the liver and the kidneys and the lungs, that ultimately he and his family decided that they wouldn't do anything, and he expired. And this man, Frankie, had he presented within the first hour of onset of chest pain, would likely have been treated with a successful PTCA, a stent, and have gone home in a day or two. And whether he might have later required a bypass operation, is a different question. But he's the kind of patient that modern healthcare can almost always save. And this man died because he was afraid to go to the hospital. And this is a tragedy. Osama commented that we've missed those dissection patients. Those are patients who typically suffer great chest pain. It typically goes through to their back, and it's a very severe pain. So most of those patients present very quickly in normal times, and we operate for them all because without surgery, more than 95% will die. So those patients are missing. Where have they gone? Well, during the time that Dr. Osama was referring to, the emergency medical services, the ambulance staff and personnel in the city of New York were instructed not to do CPR on patients in the field, and that those patients would be brought directly to the medical examiner. So I don't think it's a real mystery where those patients are. The stress of COVID did not reduce the incidence of aortic dissection. It likely increased it. But the patients who suffered it never made it to medical attention. And what Dr. Samuel's referring to at the Beth Israel Hospital, part of the Mount Sinai healthcare system, was also noted at all the other hospitals in New York. I'm part of a group of surgical leaders within cardiac surgery in the city of New York, and all of those centers noted the same absence, 70 to 95% decline in patients presenting with aortic dissection during the pandemic. And this is, just one example of kind of the worst kind of medical problem that cannot be avoided and expect to survive. But there are lots of other kinds too. I learned recently of a 30-year-old man who died of a GI bleed at home because he was afraid to go to the hospital. And that man was the son of one of our nurses at the hospital. So it's an astonishing dilemma. And I think the answer is simple. We need to encourage our patients to seek medical care as they normally would, and to know that our healthcare systems have evolved quite quickly to provide care for non-COVID disease that does not expose the patient to a risk of catching COVID. All of our staff wear proper protective equipment. The patients are tested before they're admitted to the hospital. There are only a very, very few patients in New York City presently in hospitals with COVID. The vast majority of patients in our hospitals do not have COVID. And of course, we rigorously segregate those. COVID patients are not mixed with non-COVID patients, so that coming to the hospital for medical care is very, very likely to end with your improvement in health rather than end with you catching COVID. The likelihood of catching COVID coming to see your doctor or even coming to an emergency room in New York City, at least now, is exceedingly low. So don't avoid the healthcare system. Seek the normal care that you would for your healthcare problems, because that's what's best for patients.
Thank you, Dr. Puskas. Dr. Samuel, a recent report by the American Medical Association states that the number one cause of death in the United States is cardiac disease. The number two is cancer. So those are still number one, number two. And number three is COVID. Are we giving enough attention to number one and two? Or are we ignoring number one and two and jumping to number three at the increased collateral damage because of number one and two, as Dr. Puskas has already alluded to?
Yeah, I think this year is an exceptional year, and of course, when COVID jumps up the list of causes for cardiac death to come to number three, that's a disease that only started in December. So we always paid attention to heart disease and cancer. We understood the status of as a cause of death in the population, but we never really worked our best way to get the message across and deliver it to the population to achieve all the possible preventive strategies that we can have to prevent heart disease. So there are 7 pillars of health that the American Heart Association suggests that we should all put up to prevent heart disease: avoid smoking, maintain proper weight, get your sugar below 100 milligram per deciliter, basically not become diabetic, get your blood pressure under control, get your cholesterol under control, exercise. And the message is simple, eat a certain way, of course. The message is simple, but it doesn't go into the day-to-day practice of the population. And even the time you spend with the doctor, we don't really spend on the message to prevent heart disease. We are dealing, unfortunately, with more management of the disease itself than trying to prevent the heart disease from occurring. And I think programs like this may be the best way we can deliver the message that we would rather, if you didn't have the heart condition, by doing the right things or improve your odds of not getting this heart condition that we're talking about, whether it's a heart attack or a heart failure, or aortic dissection, all are complications of high blood pressure, overweight, not eating properly. So we can try to prevent those things before they even arise, and that would be the main target. And our hope is within a year, several months, we may be able to get COVID under control to some degree, and hopefully the attention will return back to preventing the number 1 and 2 killers in heart disease.
Thank you very much, Dr. Osama. Let me shift gear a little bit out of COVID into cardiovascular disease in general. And let me prelude that by saying that this is the first of a series of webinars and seminars that we intend to have under the title of Healthcare Education Collaborative, and we will bring other parties to work with us. In this one here, we're focusing particularly on people of a Mediterranean origin, and Dr. Osama, you have that origin. Dr. Paskat, you've been to Saudi, you've operated there, you've been to Jordan and lectured, and Dubai and Abu Dhabi and many places around the world, and you, in your practice here, you operate on many people who are of a Mediterranean and Asian background. A question: are people of a Mediterranean background and Indian subcontinent at equal risk, higher risk, or lower risk for cardiovascular disease than the average American, from your experiences?
That's an interesting question. We've all read a lot about the Mediterranean diet. And I think that those people who live there and live that life tend to have a slightly lower incidence of cardiovascular disease. But when they come to America, their diet changes, and so does the risk profile. Tobacco abuse is the #1 avoidable cause of cardiovascular disease. And tragically, it's very common in the Middle East. It's even considered glamorous in many cultures. It was considered very glamorous here in America in the 1950s and 60s and even into the 70s. And the public health education initiative that finally brought smoking incidence way down in North America was initially met with ridicule and great opposition. I remember when they stopped allowing people to smoke in restaurants and bars, it was as if the sky had fallen and the devil had taken control of the government. I mean, it was really viewed as an affront to Americans. And we see in places like Jordan, where Omar and I have both worked and visited, an extraordinarily high incidence of tobacco abuse, which contributes undoubtedly to a significant incidence of cardiovascular disease. The diet has changed in the Middle East. There's a more highly caloric diet. And frankly, routine exercise as a part of life has not become the norm. So obesity, especially central obesity, and the cardiometabolic syndrome with diabetes and cardiovascular disease has become endemic. When one takes a cardiometabolic physique and metabolism and adds tobacco, you have a very explosive mixture. And so I think that now, unlike historically, presently, I think the basin, the Mediterranean basin, the Middle Eastern basin, is engaged now in an epidemic of cardiovascular disease. And the same is true in the subcontinent of India, which historically had a relatively low caloric diet and a vegetarian diet. Has changed. There's a lot of deep fried foods. They may be vegetables, but they're deep fried. I love Indian food. I love going to India. I've been many times. I always have a great time, but I'm impressed at the physiques that I see in the public spaces. Again, the truncal obesity, a cardiometabolic appearance to patients, and this syndrome ends with diabetes and premature coronary disease as an endemic problem within the Indian subcontinent. I don't think tobacco abuse is as prominent or prevalent in the Indian subcontinent as it is in Jordan and other places in the Middle East. But the cardiometabolic problem is rapidly accelerating in the subcontinent. And interestingly, from a cardiac surgeon's point of view, it produces a very diffuse diabetic pattern of coronary disease in arteries that are relatively small to start with. And so this diffuse multi-vessel disease with multiple lesions in each of the vessels becomes a real challenge whether one chooses a percutaneous stent-based therapeutic approach or a coronary bypass surgically based approach. It still is a challenge to get great outcomes for those patients.
Well, thank you, Dr. Puskas, for your comments. As I shared a minute ago, we will be having more of these that are ethnically directed. This one is directed toward the Mediterranean and Arabic speaking. And actually, we have many of our participants from Jordan and from countries of the Middle East. I see Dr. Wael Husami, a recognized professor of cardiology in the United States, frequent traveler to the Middle East. Welcome, Dr. Husami. He can hear me, but I cannot hear him. And next times we will have shows from Italy, Spain, Spanish-speaking, Indian, and Hebrew, and more. So we look forward to that. Dr. Osama, and ممكن تتكلم بالعربي هون إذا حبيت, so that we will mix it and we will show the mix. You're welcome to throw a few words of Arabic if you wish, and share with us your experience. You privately, before we came on the show, you told me about your experience in Cairo, in Egypt, when you traveled there. Share with us those parallels, please.
I agree. Thank you so much. I agree completely with Dr. Puskas. And I agree that there may be a small difference between the epidemic in the Middle East and in the Indian subcontinent. I see a lot more insulin resistance in patients from the Indian subcontinent with lower LDL levels than what we see in a white or Middle Eastern individual. But the HDL level is usually low. That's a good cholesterol, and the triglyceride is high. And 2 or 3 pounds of truncal obesity in a Southeast Asian, they just become diabetic, and the A1C increases. And the concern is whether the treatment that we normally offer a white or a Mediterranean person would be the right treatment for a Southeast Asian to prevent heart disease. In the Middle East, I agree that smoking is a major risk factor. I think the Mediterranean diet doesn't seem to go in the southern Mediterranean. It's in the North Mediterranean. We don't unfortunately eat a Mediterranean diet in Egypt or some of the other countries. There is a high consumption of unprocessed of processed food and meat, and it's certainly a big concern. I have seen very premature coronary artery disease on some missions to Egypt that I had. I see atherosclerotic heart attacks in men in their 20s who are smokers, and I have seen significant gaps of care where the standards of care, like a high dose statin, is never enforced. The treatment didn't include an absolute cessation of smoking after a heart attack in a 30-year-old with a child at home. Things like that you wouldn't have even thought that they wouldn't stress to the patient, or the choices that are being made may not be completely appropriate. So we really want to stress the need for a complete assessment of the risk factors and understanding of what constitutes a proper healthy approach to life that can prevent this kind of heart disease, and then the appropriate therapies that are available, and tailor them to the ethnic background of our patients. And that would be a very good way of doing the future of cardiovascular prevention, where it's tailored to the patient. And there are other strategies that we can go into assessing for the presence of atherosclerosis and monitoring the atherosclerosis process longitudinally in a patient, and demonstrating that you were able to abort it at where you found it. So if we see that atherosclerosis started, we do what we need to do, and then have ways of monitoring that it's not progressing. We don't want to wait till disease develops. We can try to stop the atherosclerosis in the early stages, and we have ways now to monitor it, and we can tailor our aggressive approach to treatment for those risk factors if we see that we weren't able to abort the process of atherosclerosis.
Thank you, Dr. Osama. I want to recognize some of my friends and colleagues who are online: Dr. Fahad Abu Aql, Mr. Roger Thomas in Great Britain, Abu Dawood, welcome. And I want to put forward the question that's raised by Dr. Anas Khalifat about COVID-19. We're back to COVID-19 in the elderly population, and he's quoting the case of a person who is who's older, yet he's doing well. Is age an important factor in survival nowadays in the COVID population? Dr. Puskas, you want to take a stab at it? You've treated many dozens of COVID patients.
Yeah, I wish I could say I didn't know, but I think I do know the answer to this question. And it seems clear from our experience in the intensive care unit in New York during the height of the pandemic that elderly patients did especially poorly when infected with COVID. Now, there's age related to one's birth certificate and age related to one's physiology. So a 55-year-old with a hemoglobin A1C of 14 and a BMI of 40, I think is at greater risk than a 75-year-old with a BMI of 25 and an A1C of 5.8 if they both contract coronavirus. And I will say that while it's clear globally that the majority of deaths are in patients over 65, we have also seen deaths in patients much younger than that. And sometimes patients whose only risk factor appears to be obesity. So I think obesity is a primary problem. It may have something to do with the inflammation that obesity and cardiometabolic syndrome bring to the vasculature, and then the additive effect of the SIRS response, if you will, the inflammatory response that follows the initial COVID infection. In some of those patients is quite dramatic. But I think the bottom line is the 90-year-old who sails through an episode of COVID is relatively fortunate. In several countries, including the United States, a discouraging and even shameful proportion of mortalities have been in retirement homes and nursing homes, where elderly patients have inadvertently been exposed and the virus is spread throughout a facility. And sometimes the mortality rates in an entire facility may be 20, 30, 40, even 50%. So that's something on the order of 40% of all the mortalities from the initial wave of COVID in America, and for that matter in Britain, we're in, and in Sweden, to my understanding, we're in nursing homes and elderly residences. So I think the bottom line is that age still matters, even if it's just the number that you're tracking. It seems to correlate with a worse survival with COVID. But certainly, we're all heartened to hear that our Arab patient who's 90 plus is weathering the storm, and we'll see another year. I pray 2021 will be much better.
Thank you very much, Dr. Puskas. Let me shift gear a little bit. We spoke a lot about coronary artery disease. We spoke a lot about COVID. Both are very important ailments that affect the patient population and cardiac health. What about other cardiac diseases that are less prominent, that we need to educate the public about? Valvular disease that may cause death, ventricular dysrhythmia, atrial fibrillation, myocarditis. Can you start shedding some of those lights? And Dr. Osama, you are a clinician who takes care of patients way beyond just coronary heart disease.
So obviously, the heart is like a house. So there are pipes. Those are what get clogged when you have cholesterol build in those pipes. You have rooms between the heart. Walls of the house can crumble. That's where the heart muscle can become weak with disease. There is electricity running in the house where there could be irregularities. There are doors between the rooms. Those are the valves. So all those things are areas that can get, you could get sick in one of those areas. We deal with a lot of valvular disease. The doors between the chambers of the heart can become narrow, or they can become leaky. In the Middle East, we deal with that often because of rheumatic heart disease is still prevalent, and we get patients with either the mitral valve stenosis or the aortic valve leaking, or a combination of multiple valves. Those valves also can be diseased not related to rheumatic disease. You could get born with a 2-leaflet valve that could close over time or leak over time in the aortic position. You could develop significant narrowing of the aortic valve when you become elderly in your 80s. Your mitral valve can leak very often after a heart attack or if the heart muscle is weak. So valvular disease is usually very well tolerated symptom-wise for decades. It gets detected by the auscultation of a murmur by a good clinician who listened carefully to your heart and may detect that murmur, or you start to eventually have symptoms, whether it's chest pain or shortness of breath. And then an echocardiogram, which is an ultrasound of the heart, can very quickly and easily identify the problem and assess how severe it is. It's not always necessary that something get done right away, but eventually many of the patients would need a timely choice of the procedure that is now either surgical or can be done even interventionally to prevent the complication and the irreversible damage of the heart muscle if that valve condition does not get corrected at the right time. So we see many patients with valvular disease, and rheumatic fever, unfortunately, is still prevalent. So it brings in some patients from the Middle East with cardiac disease, even here in America.
Well, Dr. Osama, this is a fabulous example that the heart is like a house with the electricity and the doors and the pipes, and etc. I've never heard of that before. I will be using it again. Dr. Puskas, you are the repairman, and you have done a lot of repair. Just working with you for the last, we've worked together for almost 25 years. Just in the last couple of months, you have done many fascinating cases. An aberrant origin right coronary artery, a mitral valve that is not functioning. Do we have to replace it or repair it? A regular heartbeat that before we used to struggle with, and now we can fix in the operating room. A patient who had COVID and 3 valves that were not working, and we operate on. Kind of touch a little bit on give us those parallels of the house repair that Dr. Osama has alluded to.
Well, I guess I would be that rabbit that you can call online, to come and fix the house. It's been an interesting time recently. One of the most unusual cases that we've done recently was a young man, a 40-year-old man, who'd worked as a delivery person with one of the local Mexican restaurants until COVID had closed down the restaurant and he became unemployed. And then he got sick with COVID himself, and he had GI manifestations of COVID. He never had the respiratory manifestations, but he had bad GI manifestations of COVID. And he was admitted to our intensive care unit during the COVID pandemic. And he was one of the very, very few cases of heart surgery that we performed during the pandemic, other than ECMO, extracorporeal membrane oxygenation, a fancy set of tubes and whatnot that we use to support oxygenation in critically ill pulmonary patients. But he was one of those few that actually had heart surgery during the pandemic. And in fact, he was the only person that we operated on with a formal big heart operation who had COVID at the time of the operation. And the problem that developed was that he had developed infection, presumably translocated from his gut to his bloodstream, and then onto 3 otherwise healthy valves. So his aortic valve, his tricuspid valve, and his mitral valve were all terribly infected and destroyed. And he was in profound heart failure. And he was actually a very fit young man who made a living riding a bicycle, delivering food, and was tough and motivated and desperately wanted to live. And we took him to the operating room, and we did what's called a commando operation. We removed the aortic valve and the central fibrous structure of the heart that was all infected. We removed the mitral valve, and we rebuilt the center of the heart with strips of bovine pericardium. This is the lining of a cow's heart. You can think of it as a very fancy kind of leather. And then we replaced his tricuspid valve as well, because all those valves were completely engulfed in infection and the tissue around them was destroyed. That man required a pacemaker as well because the electrical conduction in his heart had failed. So he had a tremendous, huge operation and survived and went home. And we recently saw him 3 months later for a final visit in the office, and he looked tremendous. He felt great. He completely recovered, and he just wants to get back to work. He wants to work. And I think that's what a lot of Americans want to do. They want to work. And I think that's part of the great frustration that we're seeing expressed in various social discontents in our society just now. Is there's a huge amount of frustration that our patients are living. And I think we as healthcare providers have to be sensitive to that. And it may be different slightly in different cultures, but there's a pandemic of frustration and angst that must reflect in a higher incidence of stress-induced cardiovascular disease. And as Dr. Samuel said, that's something we need to look out for.
Thank you, Dr. Puskas. Can you touch a little bit about atrial fibrillation and just kind of for 1 minute on the atrial fibrillation treatment and then the right coronary unroofing?
So one of the things that we've developed at Mount Sinai Morningside is an intraoperative procedure that involves ablating the back wall of the left atrium to eliminate atrial fibrillation. So patients who are coming to the operating room either solely for that, they can have it by a very minimally invasive approach without opening the breastbone. And patients who have other reasons to have heart surgery, whether it be coronary artery disease or another valve problem, can have this ablation of atrial fibrillation during the course of their other cardiac surgery. And thus far, that's been remarkably successful. We actually have 2 patients about to go home probably tomorrow who are now in the hospital who had ablation of the atrial fibrillation in combination with coronary artery bypass grafting. So yes, we can manage atrial fibrillation in conjunction with the management of other kinds of cardiac disease. And that's an important asset to the patient to not just treat their coronary disease or their valvular disease, but also try to restore a normal rhythm to the heart That's the electrical wiring in Dr. Samuel's analogy of a house. Another part of that is the plumbing, and that's the coronary arteries. As Dr. Lattouf mentioned, we've had, strangely, a flurry of anomalous right coronary arteries. So the right and left coronary arteries provide the blood supply to the heart, and they typically arise from opposite sides of the aorta, just above the heart. Occasionally, quite infrequently, the right coronary artery will arise from the left side of the aorta, and it travels for a short time within the wall of the aorta, where it may be pinched. And that can cause symptoms. It can cause patients to pass out. It can cause sudden death. It can cause myocardial infarction or just angina, chest pains. And oddly, we've had 4 patients in the last month with this problem. And I don't know whether that has anything to do with stress or anxiety, hypertension, or just play of chance. But we've employed a technique called unroofing to open up that slit-like opening or orifice in the coronary artery, and to remove the compressive part of the wall of the aorta just for the first centimeter or centimeter and a half of the artery, so that rather than doing a bypass, we simply work on the native artery, make it have a beautiful wide opening, and then these patients go home in 3 or 4 days relieved of their symptoms. So it's a niche, it's an uncommon problem, but it's the kind of thing that a center like ours, which is focused on coronary surgery as a center of excellence, can manage in a very routine and excellent way.
Thank you, Dr. Puskas. I want to recognize a note from Dr. Walid Abed from Saudi Arabia, who's sharing with us that they have similar experiences in the management of the COVID patients in Saudi Arabia, patients who have cardiovascular disease and COVID. Thank you, Dr. Abed, for your comment. We have an interesting question that has been posed to us. I want to pose it to Dr. Samuel, and then I'll ask Dr. Puskas to comment on that from a different viewpoint, because he's going to speak to this issue next week on the NAMA conference. What changes do we need to do in the medical community from a service and education to better prepare for another infectious disease? Dr. Samuel, tough question.
Yeah, I think there have been a decade or two of warning of an impending pandemic, and many smart people expected it. There were initial preparation for it, centers for monitoring the development, but I have to say that the education of the physicians, the urgent structure changes that was required to be made took us all by surprise. So despite decades of warning, we did not seem to that we were prepared at the onset of the epidemic. I think we learned tremendously from the experience, and it seems response will need to be, as you mentioned, in education, in medical teaching, and in the operation of medicine, but also in hospital administration and having sufficient resources and lines of supplies, so you could get the additional PPE and the additional needs that you have, but also somehow try to segregate and manage your regular medical needs in a safe way during an epidemic, so we don't have that same trouble where the patients are afraid to come to the hospitals, and we may have to figure out a system where we can continue to do healthcare, provide healthcare for what is needed normally in a normal time, and then manage the pandemic at the same time. But those are very difficult decisions. New York is getting a slight warning of a second wave, and I see that the response by the hospital administration is quite aggressive. They're going back into the mode of trying to figure out the response, and Fortunately, or if you could say that in March we were alone in New York who was dealing with epidemic. We had, I think, 15,000 healthcare workers coming into New York to help out. If there is a second wave in New York, there will not be 15,000 people coming because it's all over the country. We will have to deal with what we have. And I think the leadership in healthcare in general need to understand the logistic involvement. Like every other part of life that changed, kids are not going to school, they're doing remote learning. It wasn't very effective at the end of last year. We're doing it a little bit better this year for whoever has kids in school. Our initial response, we didn't have a single conference or an educational meeting in March other than to talk about COVID and give the information that we were trying to get to how to deal with it, because we felt that we're going to be seeing hundreds of patients with it, and that's all what we did maybe in March and April. But then by May or June, we started to develop a different system of education, Zoom meetings like this, virtual meetings. And there may have been even an improvement in our conferences. We started sharing between hospitals. We started getting experts that we wouldn't have had in one place, because when they physically went and there were 20 people, now you could have 500 people listen. So the educational aspect of this may have taught us a few things that we can use even for the future. And I think it's quite appropriate that as human beings with very high expectation, we should expect of ourselves to learn from something like this and come up on the other side as better individual. We should not be beaten by an epidemic. We should learn more and use it and make the other side better and more efficient.
Thank you very much, Dr. Samuel. Dr. Paskas, I know you have a flight to make. I want to give you the chance to speak for whatever period you wish and depart at your convenience. And then I will comment on this question after you, Dr. Paskas.
Thank you. Osama is always inspiring. Yeah, we will not be beaten by the pandemic. I think that's true, and I think we applies to everybody. Whether we're in New York City or in, Beirut or Cairo. We will not be beaten by this, and we will be smarter the next time. But it will be hard the next time too. And I think that what we should really focus on is trying to prevent a second wave. We can see in the major countries of Europe that daily incidence of new cases is actually at an all-time high. Italy, Germany, France, and Great Britain, all in the last several days have had higher daily rates of new cases than ever before. That's the case in the United States, not quite. We're about 70,000 new cases yesterday. I think the highest we had was something on the order of 80. The United States is roughly the same size as all of Europe. So I watch what happens in Europe, I watch what happens in the United States at large, and then I watch what happens in New York City. New York City is an interesting microcosm of our planet in a lot of different ways. We have not had a real second wave in New York. There has been an outbreak among our Orthodox Jewish friends. The Orthodox and Hasidic Jews celebrated Yom Kippur and Rosh Hashanah and Sukkot, their high holy days, without masks for the most part. And there was an outbreak in those localized communities in Brooklyn and Queens. And for a short time, the rate of positive tests in those communities was over 25%, compared to a statewide rate of less than 0.9%. But in the last couple of days, the rate of positive tests in those communities is below 2.5%. So it's approaching back down to where it should be. The local governments have taken appropriate measures to close the private schools that are run in those communities, close local businesses, and that's difficult on those communities, to say the least. But we cannot have the honest truth is that everybody must follow the same rules if we are all together to get through this without another major wave. So that's terribly important in New York City. We just 2 weeks ago on the island of Manhattan were fearful that a wave would rise up of COVID again from Brooklyn and Queens and come across the East River to Manhattan, and that we would be back in it again. That doesn't seem to be actually happening. The trajectory is very much downwards now, not upwards. And I know that there were 170,000 tests done yesterday in the state of New York, the most in any one day ever. And the positivity rate is under 1%. So I think we're not going to have another wave in New York City. I think enough of us are intent on preventing it that it won't come. But the prevention is really important. There was a lot of misinformation about the value of masks or the need to wear a mask. And this even became a political issue, which is really regrettable. And I don't say this as a partisan for either the left or the right. Both sides were wrong in politicizing it. We need to have an evidence-based approach to prevention of another wave. And frankly, that requires wearing the masks. It's a nuisance. I don't like wearing them, but I wear them every single minute of the day when I'm not alone in a room like this. We simply have to do that. And I think that's going to be a global need. I don't think that preventing a second wave in Cairo will be any different than preventing a second wave in New York City. It will require that the population wear masks. So that's my message. I think we need to focus very hard on preventing another wave wherever possible while we await a vaccination.
Dr. Puskas, thank you very much for your comments. Dr. Samuel, thank you very much for being with us and sharing your thoughts. I want to close by saying that the question of what should the medical community do, in fact, I have written a paper on that I have published in the Journal of Cardiac Surgery with my medical student, Noah Newman, in which we said that there is a need to reinvent medical education. COVID has uncovered the failures in medical education in that we put the blinders on. We're excellent surgeons, excellent cardiologists, intensivists, and so on. Very few of us have been trained in business negotiation, in finance, in contract, in strategic planning. I took a course at Harvard Medical School last year on surgical leadership. And for the first time at my age and my senior position as a full professor of cardiac surgery, I learned a lot. And I learned that in order for you to be an excellent care provider, you have to know a lot more than how to cut and sew and which medication to prescribe. You have to understand how you can create strategy. Currently, the strategy for healthcare is designed and executed primarily by politicians and business people and not by healthcare providers. The healthcare providers were the foot soldiers, and COVID has exposed us to that. I was very privileged as the two speakers here that we work in an institution where the leadership is in the hands of physicians, actually. So our leadership was very sensitive about the realities that we were facing, and they were with us hand in hand. But in other institutions, the situation was different. I think the time has come that medical schools should teach negotiation, finance, management, marketing, and political activity. Those are some thoughts that I have, and perhaps that's a topic for another conversation. We have 4 minutes before we close. I want to give Dr. Puskas and Dr. Samuel a chance to give closing remarks, and for me to say I am extremely grateful for the time and the thoughts that you have shared with us. Dr. Puskas?
Thank you, Omar. It's really a privilege to participate in this session. I always learn from Osama. We have weekly, now there's Zoom meetings. We used to have a weekly heart team conference where we would discuss interesting cardiovascular patients. And so many of the patients that I operate for originate in Dr. Samuel's care, and I always value their perspectives. This session focused on the Middle East, and especially Arab patients and physicians and care providers of Arab origin is very important. Especially in New York City, we are a very, very cosmopolitan city. We are a microcosm of the world. And we want to be able to provide culturally sensitive and appropriate care to patients of every ethnic background. Omar and I have been friends and colleagues for more than 2 decades, and Osama and I have been friends and colleagues for, I guess, about 7 years now, Osama. And so I would say that together we're going to achieve what Osama said. As is typically his case, he's inspiring, and he says we will not be beaten by this pandemic, and I believe him.
Thank you, Dr. Puskas. Dr. Samuel?
This has been a privilege to join the two of you in this meeting, and thank you, Dr. Puskas, for an amazing 7 years with your expert and amazing hands have saved the lives of many of my patients in the last 7 years, and I am honored to work with you. And Dr. Lattouf joined us this year, and I know it was a difficult time to be in New York, but we can see from the first few months your enthusiasm, your abilities, and your very clear message is really something I'm excited, and I'm quite hopeful we'll learn a lot from you and have a friendship like what Dr. Puskas has. Those programs are amazing. It's my first in this virtual way. I've done programs like this with public, with other physicians, obviously in person. But I guess this is the new normal, and I think it has this, maybe I don't know who the participants were. I'll get the data later how global this was. But it's really inspiring that we can share our thoughts in a format like this with our friends and colleagues, and hopefully we can have them on the panel. We hear their opinions and learn from their experiences. So I am certain that we can always learn from each other, and this will be for the advancement of humanity. So I would be excited to join more in the future.
Thank you, Dr. Osama. I want to thank Mr. Abdullah Al-Ubaidi, my pre-medical student who's in the background running the show. And I want to share with you that I can tell only a few of the people and where they're coming from. We have guests from Saudi Arabia, Jordan, New York, Atlanta, Houston, France, Great Britain, and more. So we have truly a global audience who have been with us tonight. It's 5:01 p.m. I thank you very much for the wonderful presentations, and we will see you again. Goodbye.
Goodbye.